consistency to make sure there are no stockouts. Myeloma is also another space where we have seen a lot of growth. For those who remember their hematology lectures, maybe they'll just remember melphalan and prednisone, but we have moved away from melphalan and prednisone, and now we have novel therapies which are actually available in the country. And last graduate student just do a study on myeloma looking at how many patients are able to do serum protein electrophoresis, which is what we use to check if a patient has measurable disease in terms of an M protein, and then how many are able to be on the newer treatments as per the protocol. And compared to previous studies, we actually found there was a significant increase, again showing the trend towards improvement of care and trying to make sure we actually adopt what is standard of care for our patients. The other area of growth in the past couple of years has also been this initiation and development and strengthening of multidisciplinary teams and tumor boards, which actually brings people from different specialties to discuss a case. You have the surgeons there, you have the oncologists, you'll have the pathologists, and this we have seen has really been fruitful. The other improvement has been in terms of our clinics organization, because before we would have both benign and malignant hematology patients reviewed in one clinic, which would happen on a Monday. But increasingly, for now, almost 2 years now, we have been able to separate those so that we have a benign hematology clinic that will deal with patients with sickle cell, with DVT, with other myeloproliferative disorders like polycythemia. And then also mid last year, there's a hemophilia clinic that's set up. So, because we know for hemophilia patients, they can get bleeds at any time. So that has been also a great achievement in terms of having a place so that they don't have to go through the long route of casualty just to get factor administered, and unless they're very unwell or critical and need to be admitted. With regards to COVID, what has been the challenges? And there's still a lot we are learning about COVID, but we know cancer patients are susceptible to COVID, and they tend to get more severe disease. And they also, because of the nature of their illness, have frequent visits to the hospital, a lot of interaction with the healthcare system. And we've actually had patients, both hematological and the patients with solid tumors, get COVID. And I think COVID made us realize really the importance of the basic infection prevention practices. And for us as a unit, we actually gained a lot in that time, because then, we had less flow of people to the ward, and therefore, limited visits. And also, we had to make sure that, especially for the acute leukemia patients who tend to stay in the ward for a longer time, they are managed in separate rooms. This also was there before COVID, but now we had to be very keen that before, if a patient has come from home, we would test them for COVID first before we return them to the same room, because they'll be with patients who are there who've been in the hospital for a long time. Our experience has been with the patients who've gotten COVID is that for patients who get mild disease, even if we've had a few patients with acute myeloid leukemia who've gotten it, a patient with aplastic anemia, if they have moderate to severe disease, then they have a poor outcome. If they have a mild disease, and the fact that the COVID diagnosis was just part of a screening that was being done, we've seen these patients actually still do okay. And usually the challenge is that you have treatment delays, because at this point, for intensive treatment, we are instituting it once they turn COVID negative. And the observation that's been made by the infection prevention team is that it's for especially the hematology cases, it seems like they really take long to convert and to get a negative test. The other change has been that now, especially for the hematological malignancies, because they get neutropenic fevers. So each time a patient has a fever, part of their workup now is, to do a COVID-19 to make sure that that they don't have the infection. So of course, as I've highlighted, there's exposure also within the facility when relatives come, and also, from ourselves as staff. So we're very keen that if anyone has any upper respiratory tract symptoms, that they should stay away, get tested, and only resume if their COVID is negative. And then, as I've mentioned, when patients get discharged, they go out to the community. We had such a case where we had a young boy with relapse refractory ALL, and he'd been with us in the ward for 5 months. So we were trying to, got the social worker involved to get him a discharge. And, he had been in the ward for so long that he had had multiple COVID tests and was negative. But in just that few days that he went home, he came back within a week with fevers and respiratory symptoms, and actually didn't make it. So, now that there is established community transmission, that also being a risk. So we've had to really encourage our patients that even, when they're with their friends, they really need to make sure they put on a mask, wash their hands, and avoid crowded places. Initially, we had challenges with blood donation, but I think as the lockdowns were, removed, and people now started interacting more, now we are having donors able to come, but there's still that laxity when you compare to before the COVID. And then, of course, the challenge, since we don't have single rooms for patients, cohorting them. And then there's the unknowns with regard to intensive chemotherapy. So as I mentioned, for us, we defer intensive chemotherapy until the patient tests negative. So thank you very much for giving me this time to share about our experience.
Thank you, Dr. Matilda. That was quite an informative session. I think I'll just ask most of the questions later on after all the presentation. I don't know, Makori, are you able to hear me? Robert?
Hello?
Yes, Robert, how are you?
I'm fine, Dr. Mina, how are you?
I'm fine as well.
Yes.
Welcome to our session. So I'm gonna share your slide in a bit. Just give me 1 second. So yeah, Robert, I think you can take us through.
Yeah, good evening. My name is Robert. I am an oncology nurse working currently at Cancer Treatment Center of Kenyatta National Hospital. I'm going to share an experience on a patient navigation program, which is anchored in our department. It's a program which is sponsored by the American Cancer Society. It came as a result of a patient need study, which was done in July 2015. of which it involved around 468 patients. And since 2015, the program had been with us since 2017. And the program itself is actually a project that aims to track patients who have been diagnosed with cancer, or who have a suspicious index through the tests which have been done, and it shows that they could be having cancer. So the program had been with us, and based from the survey which was done, next slide, it involved around 35%, 64% of which were female and 35% were male. And of course, majority were married. And it had a catchment area around Nairobi and around the counties that mostly we receive patients from. Next. Next. So from the study, some of the findings that came around, which were quite the barriers that really our patients go through, it included lack of transportation as they navigate to come to Kenyatta National Hospital. There was also challenges regarding to literacy, regarding to the disease process and the diagnosis that they have gone through investigations, because we know that most of the patients, once they were done some tests, they were actually, you could find them, those results being put on the bahashas, and then they're told to come to Nairobi, to Kenyatta National Hospital for further interpretations. There were also issues regarding to the accommodation, issues regarding to being overwhelmed with the disease. Also, there were also issues related to cost of treatment, long waiting time, among other things, as you can see from the table. Next. So from that survey still, we noted that 29% of patients had missed or delayed treatment. And also, it also indicated that most of the significant other barriers that were noted is a lack of money for treatment, transportation, accommodation, once they're on treatment, once they're on active treatment in Nairobi. Next. So from the study, we through this project, we noted that we could not afford to manage all the barriers that these patients were going through. So we prioritized through the assessment that which was done, what the patients value most. And it was noted that majority of the patients were very keen on getting help about where to go for each service within the hospital. Remember, our hospital, we receive patients from different service points, and not many will be able to navigate all the way to the cancer treatment center. Majority also wanted to get answers about their disease. And of course, the most big challenges was being hungry and thirsty throughout the day, waiting for a long time to be seen, and not having a place to rest while they are on treatment. So from these challenges, next. We came up, this program was born, and we clustered the barriers into 3 levels. From the level of literacy, we recruited the clinical navigators, who are basically nurses who are trained in palliative and oncology. And their area was to focus on helping these patients to understand their cancer diagnosis and treatment. And generally, it requires staff, and we noted that this area required staffs for it to be effective in the department. The other barriers that we noted from this, from the study, is that patients don't know where treatment service points are, from the diagnostic to the treatment itself. So we brought on board the physical navigators, and the area was to focus on addressing the physical movement of patients throughout the hospital. And we started this one by ensuring that all the team had required specialized basic training on the geographical environment of service points within the hospital entirely. And regarding to the lack of transport and accommodation, we had to bring the lay navigators. Lay navigators, basically, these are social workers whom we brought on board in this program to ensure that they support these patients, especially those ones who have challenges on financial constraints, accommodation, and also focusing on how they can partner with other good friends who can be able to support this program. So if you can look at this chart, you can see that we receive patients from different areas. So one of the areas, once the patient arrives at KNH, the program runs that once the patient arrives at KNH, the physician first has to see the patient first, so that he can be able to preempt the diagnosis or to do some diagnostic workup for staging perhaps, or another investigations that can be able to help to support the treatment itself. So from there, the physical navigators on the process, they come on board to help and guide these patients to appropriate clinics and service points. Remember that the laboratory diagnostic centers are not housed under one roof because of the disintegration of these services. So we use these physical navigators to help the patients and caregivers to be able to know which areas different labs are, and of course, any other supporting system that may be needed, including even taking them by stretchers and wheelchairs for those ones who can not be able to afford to walk around. We also include the lay navigators. Once these patients are seen and perhaps they have challenges, we also have the lay navigators in the same department. So that once these patients are assessed and are identified earlier through the clinic. Once the patients come from the physician, the patient is sent to the clinical navigators, and in the clinical navigators, they provide more information regarding to the cancer, the disease process itself, and any other concerns that perhaps was not addressed at the physician's level. So the patient also undergoes diagnostic tests and obtains referral to CTC. So once the patient has been seen and through the clinical navigation, and perhaps it's identified that could be having some concerns regarding to the accommodation and the financial constraints, is referred to the lay navigators, who are basically the social workers. The social workers also now at this level assesses the needs and makes referrals to different KNH services or to different partners, perhaps whom they have linkage, so that they can support these patients. At the lay navigation level also, they are also linked up with the chaplain or for spiritual support, and another psychosocial and spiritual needs are also catered for by the lay navigators at this point. So the clinical and lay navigators continue to assess patients for needs throughout their treatment. And in every encounter, these patients are supported keenly by this team that we have on board. Currently, we have 6 clinical navigators who manage the department itself and also other clinical departments like Hemato-Oncology, Obs and Gynae areas, so that they can be able to track these patients early and navigate them appropriately. We also have we have 3 lay navigators, and of course we have the 4 physical navigators, and all these teams are supervised by the project manager, who is housed also in the Cancer Treatment Center. So far, since the program started, we had our objectives that we wanted to meet. We had clustered these objectives into long-term, intermediate, and short-term project objectives. One of our intent of long-term objectives is to ensure that there is improvement in clinical outcomes of cancer patients through this program. Our intermediate objectives is to increase the number of patients adhering to their treatment plan. And indeed, we have seen a lot of success when we compare this, when the program came on board and before. There's a lot of patient compliance in terms of their appointments and treatment. The other objectives includes improvement in the overall patient experience while seeking treatment at KNH hospital, improvement in healthcare workers' knowledge and attitudes towards the use of compassionate patient-centered cancer care. And this has been indeed supported by the information education materials that we have through the American Cancer Society and King Cancer. The other objectives, intermediate one, was to increase the number of patients accessing available resources to overcome barriers during their care. Some of the short achievements that we have seen that have happened since the program started includes increasing in coordination, stroke referral between departments, and the intra-navigators themselves. It has also increased patients' ability to move successfully around the KNH while they are seeking their services. This has been enhanced through the patient access representatives, whom other departments call the porters. It has also increased in patients' understanding of the importance of adhering to the treatment plan, because in every appointment, we usually have a family conference that is facilitated by the clinical navigators. And this includes the patients themselves, and of course, the caregivers who usually support these patients. For this program to go on, we usually do monitoring and evaluation we have a monitoring and evaluation framework. And beside the baseline data that we did before, we usually carry on quarterly patient surveys to as an indicator to see indication to get indicators of how far we are doing. We also do a monitoring and evaluation, and this is done through patient survey, and of course physician and staff surveys, and of course chat reviews. This is which we have in the department. So basically, to conclude, say that it had been a very successful story for this program, and we hope that it will be appreciated by the hospital so that it can be rolled out to the other departments that don't have this patient navigation program. Thank you.
Thank you, Robert. That was a very informative discussion. Personally, I work in Kenyatta, and I am very unfamiliar with that concept. It's a very new way of approaching, because cancer is a chronic illness. You have to have a way of always monitoring this patient, and I know Kenyatta has a very huge flow, so it can be very challenging. So with me is I don't know, Dr. Moki, are you able to hear me? Dr. Moki?
Hello?
Hello? Hi, Doc.
Hi.
Hi, how are you?
I'm very well.
Yeah, thank you, Dr. for joining us. Thank you very much for joining us on such a short notice. So Dr. Moki is a surgeon, breast surgeon, who has an interest in cancer patients in KU. So just a few questions, Dr. What's the background in KU? Have you started seeing cancer patients? What are your experiences and what have you?
Thank you very much, Dr. for the invite. Albeit brief notice, but we will have this talk. I am relatively new to the institution, and the institution is also relatively new. But in terms of cancer work, a lot more has been going on there. There's management of practically all cancers, from hematological to solid tumors. In my area, which is general surgery and oncoplastic breast surgery, we are involved a lot with esophageal cancer, bowel cancer, and as well as breast cancer. So we have a panel of oncologists on board, and we equally have, we also have 3 surgeons on board. We have other surgical specialties in place. And also, you know, we have nurses who are involved in that. We have palliative nurses. I think we are in a good place, and we are looking forward to a lot more.
That's great, because I believe KU will soon be our center of excellence for cancer. It's one of the few public hospitals that has radiotherapy services. So anything like, how, I know you guys just started, but how did COVID affect you? I'm sure it's affected you like every other hospital.
Yes, I joined KU during the COVID period, and but generally what I would say is that we have been seeing patients who are presenting a bit more late. I don't know if we can entirely blame that on COVID, but I believe that it is a big contributor to that. In addition to that, I would say issues of, you know, because healthcare is not fully funded in our country. So issues of funding for the service provision is an issue. Some of them we can blame it on COVID, because, you know, we know that people have lost jobs and there are sources of income. So some of the things that, like, you know, investigations, some types of chemotherapy that is needed, even issues of you know, funding for surgery. Again, apart from that, I would also say that you know, the procedures that we have required, like you know, like in endoscopy, you would require a patient to have a COVID test before that. So, and again, patients have to foot that bill. So there have definitely been hiccups which have been brought in by the COVID situation.
Yeah, I think it's a huge challenge everywhere. Nobody's able to do anything. You want to do surgery, you have to have COVID test. You want to do everything. But I pray that soon enough it will be over. So thank you, Dr. However, you can just join in, because we have series of questions that probably I can start asking. But before that, Dr. Elias Meli from Mdrh, how are you? Can you hear me? Dr. Meli?
I can hear you, Amina.
Yeah, so thank you for also joining on such a short notice. We had World Cancer Day, so we just wanted, in fact, all of you, thank you very much for joining on such a short notice. We had World Cancer Day, and we also had to present something and know what's happening in other forums. So Dr. maybe you give us a background of Mdrh, what's happening in Mdrh? What type of services do you offer? What's unique about it?
All right. Thank you, Dr. Amina. I'm glad to be part of this important webinar during this important day that we commemorate or mark World Cancer Day. My name is Dr. Meli. I'm a clinical oncologist by training, and I work with Moi Teaching and Referral Hospital at the Chandaria Cancer and Chronic Disease Center. Moi Teaching and Referral Hospital is a multi-speciality hospital with now almost 2,000 bed capacity. And we are glad that over the last 10 years, we've had a lot of milestones with regard to cancer treatments. And it's quite exciting for the western part of the country, since this is a hospital that serves more than 20 million Kenyans from western part of the country and also eastern part of Uganda and South Sudan. So it's quite an important center that the services we provide there would not go unrecognized. Specifically at the Chandaria Cancer and Treatment Center, cancer, as my colleagues Matilda and the team have mentioned clearly, cancer treatment is multidisciplinary. And we have embraced that at Moi Teaching and Referral Hospital to make sure that all the specialties involved, from prevention from promotion, prevention, screening towards early diagnosis, and diagnosis itself through pathology departments and radiology and imaging, as well as treatments that are available, which includes surgery and chemotherapy, as well as all the other systemic agents which are available locally and affordable. And very recently, this week, we launched our radiotherapy services. It is quite exciting for us and for our patients. And certainly, we probably are the ones who are marking this World Cancer Day in a very special way. It is good news for our patients who require radiotherapy at the western part of the country. Now, at the Chandaria Cancer and Treatment Center, we do have a Hemato Oncology department, which division or directorate, that is how administratively Mdrh is designed. We have a director and who heads the Hemato Oncology Directorate, which has several departments: medical oncology, radiation oncology, pediatric oncology, gyne oncology. We have surgical oncology, and we also have palliative care. We do also have screening programs for cervical cancer and breast cancer. And I forgot hematology, which is also one of the key services that we provide there, both benign and malignant hematology. We also have very active pathology department, and we do have basic pathological diagnostics, which includes cytology and histopathology. In hematology, we also do flow cytometry, which is probably the most advanced that we are able to do right now to diagnose malignant hematological conditions, mainly leukemias. And we have a very able pathology team, which they have trained both in anatomic pathology and hematopathology, as well as cytology. We do recognize and appreciate that for us to provide quality cancer treatments, we must have also quality diagnostics. Radiology and imaging has also improved significantly over the years, and we do appreciate Mdrh management for investing in infrastructure and equipment to ensure that we are able to do the much we can with limited resources to make sure we diagnose at least over 80% of our patients well. We do, of course, are ambitious to get more diagnostic modalities for us to characterize and individualize care for our patients, which hopefully through imaging, we look forward to a time when we can do nuclear imaging as well as more interventional, imaging procedures, either for diagnostic purposes, therapeutic purposes, with curative intention or palliative intention. But as at now, we have a goodwill from our management to make sure that that is done in the soon, coming time. We also have hope that soon we will have a molecular laboratory to ensure that we are able to do molecular diagnosis to further characterize these tumors so that we can understand and probably target it better with available therapeutics, which we have learned through our evidence-based practices and clinical trials. I will also emphasize that we have a very active cancer registry, which is called Aldolite Cancer Registry, probably the first cancer registry in this country, and it's a very successful, well-managed, well-operated cancer registry. We published our data last year in Clobacon, and that is available. So we are glad that we are able to have local data in this country that can guide, decision making both at policy and clinical care from our Aldolite Cancer Registry. I will also want to go specifically to the treatments that we provide. We have, as I said, able, well-trained, competent staff who are oncologists at those department staff, who majority of them have also earned their training through our local training programs, and currently have a gyne oncology fellowship program that has produced very competent, trained gyne oncologists for this country and also for export, because we've had students from neighboring countries as far as Congo, Uganda, and Tanzania, and a majority who are colleagues from this country. We currently also have a pediatric oncology fellowship program, which is currently running the first class, and we are excited that we should be able to be a hub of training to build capacity for oncology in this country. We have our medical oncology fellowship program, which is in the works, waiting final approval with the Senate through Moi University. We have a very strong partnership between Moi Teaching and Referral Hospital and Moi University, and we do embrace that our motto in Mdrh is focusing mainly on care, training, and research. So at all times, any program designed should be able to provide those three services. And our partnership with Moi University and AMPATH, which is a consortium of North American universities, has played a very big role in building capacity for cancer care at the western part of the country through Moi Teaching and Referral Hospital. Now, we are able to offer chemotherapy. We are at we are able to offer systemic treatments, both chemotherapy and targeted therapies, which are available and affordable for our patients. And we are able to provide surgery and radiation, as I've said.
That's nice.
Allow me now to talk about COVID-19, because I know we are running out of time.
Yeah.
That is the background, that is the much we have and more that are coming up soon. Now, COVID-19 definitely caused disruption of services across all sectors, and public and private. And we recorded a lot of delays at all levels, from diagnosis to treatment to follow-up. And certainly, some of our patients were diagnosed with COVID-19. And unfortunately, we lost others who had comorbidities or advanced diseases, or those who could not get care the soonest, mainly high flow oxygen and antibiotics, very strong that was constituted across all cadres, which was led physician, specialist physician. And we treated our patients because we knew that the exposure was the same since the disease was already in the community, but we took urgent and quick preventive measures as per WHO and Ministry of Health guidelines. And we are certain that we were able to prevent more spread. We reorganized our clinics to make sure there is less exposure to patients, relatives, and staff. And what we cannot account for is some patients who did not come back for follow-up, and we cannot account for where they are, because some of these patients might have unfortunately been diagnosed with COVID away from the hospital, and we don't know their fate. Otherwise, we did our best to adjust to ensure the services were running. We never closed down our services. Some departments like surgery had to be very keen and probably reduce their cases to as emergency cases only. And we recorded a challenge because treatments, breast cancer and chemotherapy, you wouldn't actually need an emergency surgery at a time like that. And we know that definitely had a challenge. We also had a problem with referring our patients who needed radiotherapy at that time, either to KNH or to private hospitals or to KU. So, because transport was an issue, and we know public transport was interrupted seriously. Just like my colleagues have mentioned, COVID-19 never spared us. We had challenges. We thank God that ultimately these years have resumed to normalcy, and we are still keen to make sure that all our patients and relatives who walk to the hospital are able to wash their hands by the main hospital entrance, sanitize where they can, and we are still working to ensure that there is social distancing and masking to avoid further spread or risk contacting COVID-19.
Yeah.
Thank you. Otherwise, allow me to stop there and questions just in case there is some. Thank you, Dr. Amina. Appreciate it.
Yeah, thank you, Dr. G. You have informed us a lot of things. I was not aware about the radiotherapy services. So I think that's a very key thing for us to know. So I'm just going to ask a few questions from the question and answer panel. A question here is, a patient with the small cell carcinoma with a HB of 4.6 and also with cardiomegaly has been transfused with 5 units of blood, but recheck blood is 7 after 3 days. Is it advisable to continue with transfusion? How do you recommend, considering that the patient is desaturating on oxygen levels? I think Dr. Matilda and Dr. Elias, one of you might answer this question.
All right, thank you very much, Amina. I think if I get the question there well, the concern is this patient has cardiomegaly, and then you're worried you're going to give more volume to this patient, and yet you need to optimize their blood level, especially in case if you're planning treatment. I think one of the important things is when we transfuse patients and then their hemoglobin doesn't rise to the expected level. So usually we say it should increase by 1 to 2. So, you know, if it was 4, you say the HB was 4, you've given 4 units. So it's not an absolute that, you know, it will increase to 8. So 7 is not too bad. But then I would not be afraid to transfuse this patient, but then there are a few precautions. If you have packed red blood cells, that would be better than giving whole blood. These are the patients who you transfuse and give a dose of Lasix so that they're not going into fluid overload because of the volume that you're giving. And then also spacing out the transfusion so that you're not giving them too much volume within a short time. The other thing I would make sure is that they're not having any other losses or any other condition that would affect the increment. So blood is cross-matched, type 10 cross-matched before it is transfused, but especially patients who've had repeated transfusions become sensitized. So you have your major antigens and your minor antigens. And sometimes if you have a patient who's alloimmunized, you may not get a good increment. The last thing I would add is you say this patient is on oxygen. So many things can cause hypoxia. So you have to step back and find out, is this hypoxia because of infection? Is it that the patient is in heart failure? This patient has a malignancy. Could they have a pulmonary embolism? So also interrogating what else could be contributing to the heart failure, to the hypoxia, because I don't think it would just be the HB of 7. Maybe there may be other things. And you mentioned, you know, given that this is, I don't know if I got it correctly, that it was involving the lung, you know, how are the lungs affected? So that if you have significant parenchymal lung disease, that may also be the contributor for your hypoxia. Thank you.
Thank you, Dr. Dr. Elias, do you think you want to add extra or it's fine?
Well, I think Dr. Matilda has comprehensively covered possible differentials, and I concur with everything that she's mentioned. Only to focus on possibilities of lung collapse, probably from the small cell, lung cancer, or possibilities of any pleural effusion, just broadening, the differentials diagnosis for the cause of hypoxia and making sure that we also address the primary cause as we supplement with oxygen therapy.
Thank you.
And it's also good to centrally find out possibilities of could there be central problems that is leading to hypoxia. With lung cancer, we know the risk of brain disease involvement is quite high.
Thank you, Dr. Maybe just to add, I've become a COVID specialist. We need to rule out COVID in this patient as well. On a late note, Dr. Lando, I don't know if you're with us. There's a question here regarding esophageal cancer. What are the risk factors of esophageal cancer apart from hereditary? And how is stenting of esophageal cancer a risk to jaundice to cancer patients?
You can hear me?
Yes.
So the risk factors for esophageal cancer are studied from different parts of the world. You have low serum selenium, you have hot foods and drinks as was described in Iran. You have tobacco, alcohol, low socioeconomic status, poor oral health have all been attributed to an increased risk of esophageal cancer. Then when it comes to stenting and jaundice, I have not heard of that or experienced that before, so would not be able to provide an answer to that effect. I haven't seen any patients that have had stenting present with jaundice subsequently, unless they had other comorbidities by the time they were getting the stent placed. Yeah.
Okay, thank you. And I think the last question they had asked was, is there any organization supporting cancer surgery in Kenya? I think you mentioned something about some partnership that give you stents or something. Maybe you can expand on that.
So the partnership that I was talking about is with because we work together with Boston Scientific, the company that makes stents. And so the idea is, how can we provide affordable stents in our setup? And so they graciously, as a part of the corporate responsibility, and also in trying to help with the research projects within Africa and finding out what are the risk factors, then they provide the stents that we are able to place for the patients. And so, as I said, for the stents themselves, for the patients actually pay for the cost of getting the stents to the different facilities within Kenya and Africa, but they don't pay for the stents themselves. And this is in conjunction with, I said, TENEC being a member of AFREC, it stands for African Esophageal Cancer Consortium. And there are different countries that are associated with it, from Tanzania, South Africa, we have Malawi. I think majority of the members are also in Kenya. And the idea of the consortium, or the objective of the consortium itself, are to raise awareness about esophageal cancer in Africa, support researchers, coordinate case control studies, making stents affordable as part of the objectives that's throughout Africa, and also trying to develop early detection and treatment programs for esophageal cancer. But I think that answers the question. Yeah.
Yeah. Thank you, Dr. Ali.
Okay.
Thank you very much, Doc. But just before you leave, this is an area that I was quite interested in. Yeah, I'm online. I just switched my device.
Dr. Amin, I have a question for Dr. Orlando.
Yes, kindly.
Now, it's around the complications with stenting. For me, and lower third, caused definitely by cancer of the esophagus. Now, I find a lot of challenges with pain, chronic pain, and cough. And sometimes risks with perforation.
Yes.
I have tried to
Hello.
Hello.
I think lost him.
Yes.
Thoracic surgeons stenting, and sometimes elaborate on how do we address, which is chronic in almost.
Sorry, we kind of lost you.
Can you hear me, Amina? Can you hear me now?
Yes, we can hear you
Yes,
now.
we can hear you now.
Dr. Orlando, can you hear me?
Yes, but you are breaking up. I don't think I had most of that question, or
My concern is about chronic pain and cough post-stenting.
yes.
It makes quality of life of more than 95% of patients that I take care of miserable. Is there a way we can address this? Is there a way we can prevent persistent cough and pain post-stenting for patients who can live longer than 6 months?
Because when we place in the stent as a palliative means, the idea is that they are able to feed, and so for the chronic pain and cough, because I know we always prescribe morphine, and I'm sure morphine is given from a palliative standpoint. For those that do develop fistulas, whether it's as a result of tumor progression or as a result of the stent, we end up placing in another stent to help that. But in most cases, for the chronic pain and the cough, we mainly prescribe morphine. Granted that we are mainly doing this as a palliative procedure so that they are able to feed. I don't know if that answers your question, but yeah.
It partly does. We
Yeah.
also have those patients who have localized cancer of the esophagus.
Yes.
Who could benefit from radiotherapy as a palliation also that can ultimately relieve the obstruction.
Yes.
Should we be considering G tubes for such patients? Because once the lumen is back and it's able to work efficiently, then we can pull out the G tube and save these patients permanent or long-term stents.
That is a possibility. For the majority of the patients who come to Tenwek, the only people that we don't place in stents are those that have very high tumor right at the upper esophageal sphincter, since that would might interfere with their breathing. And so for those ones, we do place in G tubes. As regards to places, not placing in a stent for them to have radiotherapy, and majority of the patients that we see have been given that option, and either one would be too weak to withstand the chemoradiotherapy, whether it's palliative or not, and so having them get the stent seems like the best option at the time. We've had a couple of people who've had chemoradiotherapy and presented to us with strictures post radiotherapy, making stenting also a bit difficult. I'm yet also to find out whether or not it's possible to give the radiation, the palliative treatment with a stent in place. I know there's a fear and risk that the stent might migrate, but for them to be able to feed and at the same time not end up having a surgical procedure for a patient who is relatively unwell, I think it's a great option. Yeah.
Thank you.
Thank you.
So there was a question regarding breast. Yeah, maybe Dr. Moki, I don't know if you're there. Somebody was asking, when is it advisable, I think, to do mastectomy? When do you start chemotherapy post mastectomy? I think we are seeing a lot of breast cancer patients having time for remission and then they get the cancer back? Maybe you can answer that.
Yeah, for the interval between surgery and chemotherapy, it's usually best if given at least within 4 weeks. But usually, occasionally there are some issues which come up. So we can extend this to at least 8 weeks. But that's, you know, so 30 days, beyond 60 days, then it becomes a bit more dangerous, because now you'll have start excluding that benefit of having given the initial treatment first, and you'll increase the risk of getting recurrence, especially with distant metastasis. So usually earlier the better. If there are constraints, then push it to at least before 60 days are over.
Okay, thank you. There's a question here. Somebody is asking, what radiotherapy is being used in Mdrh? Dr. Elias, what radiotherapy machine is used at Mdrh? Okay, I think I lost him.
We have a Linux machine. Can you hear me now?
Yes.
We have a Linux radiotherapy machine, and we are able to do both palliative and curative treatments, because we have a CT simulator. We can do 3D planning, 3D conformal planning. We can do 2D planning. And as soon as we, continue working, we will upgrade to more advanced radiotherapy treatment planning. We also have a brachytherapy machine.
Wow. Okay. Thank you. That's quite informative. I think for the people who are on different counties, probably they can take advantage of that, especially from the Western area. So maybe just to recap on the talk, we had a very informative session today. Basically, we've learned a lot about esophageal cancer, which is happening in Tenwek Hospital. We've heard about their mortality, I mean, survival rate of the patients. We've also had a brief introduction in Hemato Oncology, what's happening in Kenyatta. And I found it very interesting, by the way, Dr. Matilda, that we actually pay, NHIF covers for monoclonal antibodies in the public hospital with NHIF.
Yes, it does.
Yeah, that was quite interesting. And as for KU, Dr. Moki, thank you very much for telling us about KU and the services that they offer. I believe now that we are here on this platform, we'll get a lot of patients who now will come and engage despite the COVID pandemic. Regarding the patient navigation, I found it very, very interesting, because it's very hard to navigate, especially in Kenyatta, because it's a massive hospital. And I think that program is very, very good, and we can be able to replicate it in other forums, especially in chronic scenarios. Maybe if guys want to have more engage on that specific program, I think we can organize another session on that. Regarding Mdrh, at least now we know there's radiotherapy service, and you're right, Dr. Doc, for saying that you have uniquely celebrated the World Cancer Day, because that's a very huge achievement. But I had one question about the screening services. So Mdrh actually does screening services for cervical and breast cancer on a normal day-to-day activity.
Yeah, it is a service which runs to 5 p.m.
Ah, okay. Okay. That's nice. I also loved that.
And beyond screening services at Moi Teaching and Referral Hospital on daily basis, we also have outreach programs for screening to different parts of the Western counties.
Yeah, I think we're also engaging in a lot of those outreaches. Maybe one of these days we'll do one together.
I also found it very interesting that you have fellowship programs. I believe KNH also has fellowship programs,
That is
especially on the,
great.
yes, on the medical oncology. I'm not very familiar on the pediatric oncology. Maybe Dr. Matilda will be able to tell us if it's happening or not. But
So what's happening? Sorry.
Yeah, go ahead, Doc.
What is available currently through the University of Nairobi in collaboration with KNH is a medical oncology program, a fellowship program, which is a 2-year program after training as a physician. That's a background of Masters in Internal Medicine. And then this year, there's a radiation oncology program, actually at some point last year, that was rolled out, which is, I need to confirm the duration. I'm not certain on the duration, but which is a program that's
It's 4
after
years.
4-year program after they do working as a medical officer with, a degree in MBCHB. Thank you. At the moment, there is no pediatric oncology program. Yeah. Then there's also nursing oncology program through the university.
Yeah. So I believe we've benefited a lot from this talk, and we've learned very many different aspects. I'm sorry I didn't get time to organize it extremely well. However, I hope we can have more of these discussions. Thank you very much, the panelists. Unless you have any questions or comments, I think it's the end of the session. Any comments?
Mine is just to thank you for putting this together, and to, at the end of the day, wish everyone a happy World Cancer Day, and to just encourage whoever may be out there in the counties that and I'm sure this spells true for the other institutions as well, that we are available for consultation. Should you have a patient who you're not sure what to do, sometimes just picking up the phone and calling and having that discussion, so that we can be able to guide what can be done to optimize the patient, what can be done locally, so that by the time that they're being referred, we actually have an effective referral that delays treatment, and also a timely referral to have better outcomes. Thank you.
Thank you, Dr. Ray. Any parting message, Dr. Lando?
Mine is to thank you, Dr. Amina, and the
Yeah, so yes, Dr. Ray. Dr. Elia.
Yeah, I was saying that I also do appreciate that yourself and the team took, your special time to put this together. I would just want to request that if it's possible going forward, since we have 3 tertiary institutions now, KU, KNH, and Moi Teaching and Referral Hospital, if we can get an opportunity to standardize our protocols so that we can, as much as possible, provide care which is standardized in this country, and also possibly do joint research so that we can take care of our patients using our homemade evidence-based protocols.
Thank you, Dr. Ray, for that suggestion. I believe it's a well-worthy one, and we'll venture into it. I will contact you myself to be able to do that. Dr. Moki?
Mine is to thank you for the invite into this forum. And I think my parting shot is to encourage, for those in facilities where they are not able to offer them, the holistic cancer care, to have, early and appropriate referrals, so that patients don't present quite late when the options of treatment are limited and not as effective. And I'll also probably welcome that invite for the 3 referral hospitals to standardize care and joint research. Thank you.
Thank you. Dr. Lando? You're the first and the last to speak today.
Yeah, just to thank you for the organizers for this forum, for the opportunity to speak here, and that we continue working together to fight cancer and see how best to prevent and treat it, whichever arm we fall in. But it was a great opportunity and we're very grateful. Thank you.
Thank you very much. So I guess we'll have our next experiences. This will be organized with our other partners on pediatric cancers next week on Thursday. So until then, tomorrow we'll have the normal experiences in COVID management at 10 by Dr. Lois Acheng and team. Thank you very much for joining. Have a good day.
Thank you. Bye-bye.
Bye.
Good night, Amina.
Good night.
Thank you.